part of our brain here, are responsible for short-term memory and consolidation. Okay? So you're told some information. That information gets stored in your short-term memory in your hippocampus until your brain decides what it wants to do with it. If this is important information that you need to try and remember, then it will attempt to be stored for later retrieval. If it's not important, then it will flitter away and be erased from your mind. Your brain actually does a lot of processing of that information during sleep. Sleep is that defragmenting time in your brain where it's taking all that information stored in your hippocampus and sending it off to areas of your brain for later retrieval should you need it. So, let me back up here. Whoops. There we go. Hold on, I'll go like this. It's this hippocampus here. Remember in that Alzheimer's picture? That was just destroyed, gone. So what's the hallmark symptom of Alzheimer's? Is that short-term memory impairments. They don't receive that information. It never gets stored. So information that you tell them, short-term memories, never get stored in the brain because they don't have the option of going to the hippocampus because the hippocampus is no longer there. So, common symptoms and strategies in dealing and working with a memory-impaired individual. Well, one is knowing that a memory-impaired individual may not benefit with prompting. So let's look at Alzheimer's, for example. You can tell them as many times as you want, don't you remember, Mom? Dad, I told you this last week. We talked about this already. It doesn't matter because the information never got in to begin with. That's a hallmark symptom of Alzheimer's, where storage capacity doesn't exist. Vascular dementia, it's different, oftentimes, where the brain can store the information, it's in there, but retrieval, it can't retrieve it. So if you say, don't you remember, Mom, I told you this? No, I really don't. No, we were in the kitchen and we were having a cup of tea. And it was raining outside. You start to direct the brain to that information. Oh, yeah, I remember now. We were talking about so-and-so. That's a vascular dementia symptom. Because what happens is that in vascular dementia, the hippocampus is still functional, oftentimes. And therefore, it is able to take in that information, consolidate the information, and send it out to areas of the brain for later retrieval. But it's the retrieval process that breaks down. So if you're able to prompt the brain, then you can sometimes retrieve that information with a little bit of hint and support. Diagnostically, this is a huge diagnostic thing that we look for on testing. Memory testing, we assess, is it a retrieval breakdown or is it a storage breakdown? So do not ask if they remember. If we know that their storage does not exist, asking if they remember is just going to make them feel bad. Memory cues may not work, especially if they are not explicit. Okay? So if you're reminding them to take their medication, it's not just take your medications, but you need to take this medication at this specific time and then this one and this one, I guess as an example. So common symptoms and strategies, again, with memory loss, it's associated with rapid forgetting. So you tell them something and 2 minutes later, it depends on the severity, but 2 minutes later, 5 minutes later, 10 minutes later, they don't recall the information. So what does that mean in a person's ability to take their medication, okay? Or remembering to eat and hydrate themselves, or following instructions? What about them being able to use memory aids or other types of aids? For example, the first alert pendants, the life alert pendants. Those work really well if you have an intact brain that can remember what it's for. But if you don't remember what it's for, you're not going to know to use it, especially after a moment of crisis when you've had a fall. Same thing with medications. The system may work for a lot of patients. They have a routine that even though they have severe memory impairments, their routine works for them. But guess what? Is that as soon as they get distracted or something gets in their way and they break from that routine, medications become a problem. Can you use memory impairments to facilitate care interventions? Yes, you can. If you have somebody that's insisting on driving, no matter what, and every time you tell them they can't drive and it just causes a big argument and fight, we'll use the fact that they have rapid forgetting and memory impairments to facilitate that intervention. The car gets towed away. Instead of, where's my car? No, Dad, you can't drive. It's, oh, it's at the mechanic's, Dad. Even have a pretend mechanic call. And then when he asks again in an hour, it's the same story. So you're using the fact that they can't remember in order to help keep the individual calm and help them maintain their sense of dignity and autonomy, and it's not causing this fight and catastrophic reaction. They can't learn new information. You have short-term memory deficits, you can't learn new things. So does arguing work? If you can't learn something, then arguing does not work. Why do we argue with people? We argue because we want them to think that our point of view is the best point of view and therefore they'll agree with us. In order for them to do that, they need to be able to learn from us. Well, if you can't learn, then arguing is not going to work. And the patient will have difficulty learning from their experiences. All right, executive functions, so frontal lobes. Executive functions are responsible for our planning, our problem solving. They're the chief executive officer of our brain. It's in our frontal lobes. Our orbital frontal lobe, which is the underside here, is responsible for decision making, rewards and consequences. The dorsolateral frontal lobes, which is the top, motor planning and organization. Our medial frontal lobes, which is kind of deep and inside in the middle, responsible for music memory, music appreciation. I bring this up here because that is oftentimes untouched. It is so deep and so buried, untouched by dementias. You can have advanced stage dementia, the patient can't even talk. You play a tune from their younger days, they can sing it, no problem, and their face just lights up. It's because this is the medial prefrontal cortex that is untouched by the dementia. So intervention and strategies. Well, what can be prominently affected? Well, finances, number one, problem solving and tracking. It's a frontal executive function. Cooking, sequencing, alternating attention. Driving, problem solving, shifting and sustaining attention, to name a few. All those can be affected with executive function deficits. ADLs, activities of daily living. Sequencing and sustained attention. If you have severe executive function deficits, dressing could be quite a challenge for you because there's so many different steps that we take for granted, but sometimes you'll see they put their underwear on over their pants. Try to put their shirt on as their pants, vice versa. This is a big one, susceptibility to undue influence. It's that problem-solving, awareness, and judgment starts to decline, they're more susceptible to undue influence. Impulsive. They may say things out at restaurants that they normally would have never said because as the filter is gone that our frontal lobes provide us. In judgment, which I mentioned. So what sort of strategies? Well, the care provider will need to become the client's frontal lobe, will need to become the loved one's frontal lobe. So if a loved one has difficulties driving, or excuse me, not driving, if a loved one has difficulty dressing, rather, instead of just saying, well, get dressed after you get out of the shower, and it causes this confusion, and so you just give up and you just do the dressing for him, and that causes more energy on your part. Well, instead, take out the clothes, sequence them on the bed. Underwear, socks, pants, shirt. In the bathroom, toothbrush, toothpaste, next to each other. You provide the frontal functioning for them in order for them to function. Because we still want to be able to have the patient, the loved one, feel useful, feel like they can still accomplish things. So let's help facilitate that the best we can by becoming their frontal lobes for as much that is needed. In some neurological illnesses, these areas can be rehabilitated and even improved upon. It just depends on what the diagnosis is. That's why it's important to have a diagnosis and then order to see what rehabilitation potentials there are. And language functioning. The left hemisphere of our brain is responsible for language functioning. In most individuals, about 10% of the population that's flipped